we are going to welcome both a new speaker and a veteran speaker to the CyberMed Summit today with a fireside chat. I'm going to allow you both to introduce yourselves, please, with more verbosity, but I want to encourage everyone out there for a warm round of applause for Nitin Natarajan, the Deputy Director of Cybersecurity and Infrastructure Security Administration, CISA, as well as Jessica Wilkerson, the Cyber Policy Advisor, the Office of the National Cyber Director. Please give them a very warm CyberMed Summit welcome. As I alluded to, we're going to be allowing them to do a little bit more introduction. So if you could each please take a few moments to briefly discuss your career background, your development in the interest of serving healthcare cybersecurity, as well as a kind of maybe a current project or issue that you would like to bring to the attention of our attendees today. Again, thank you for joining us.
Sure. Thank you for the warm welcome. So like Christian said, I'm Jessica Wilkerson. I'm a cyber policy advisor with the Office of the National Cyber Director, which is a relatively new office within the White House, headed by Director Chris Inglis. In terms of background, I was just with, and I don't want to confuse everyone, but I'm also still with the Food and Drug Administration. Suzanne, who just spoke, is my boss. I've had the honor of working under Suzanne for several years now, and had the honor previously of working with her when I was with the Energy and Commerce Committee on the Hill, where is the first place that I sort of really developed my interest in healthcare cybersecurity. This was back in sort of the 2013 to 2017 timeframe, when we sort of knew there was something to this healthcare cybersecurity issue, but we didn't know exactly what, and we weren't exactly sure what we were going to do about it. So I have sort of grown up professionally with healthcare cybersecurity, going from the Hill to a brief stint in the private sector to the FDA, and now to the Office of the National Cyber Director. So I am very excited to be here, and I will turn it over to my fellow panelists.
Great. Thanks, Jessica. By afternoon? It's afternoon. I don't know what day of the week it is anymore, much less what time of day it is. So thanks for the opportunity to be here today. My name is Nitin Natarajan. I'm Deputy Director of CISA. My background in a nutshell is I actually spent 13 years as a medic and flight medic before going into hospital emergency management, before going into public health, before going to HHS, where I led the Sector Risk Management Agency for the healthcare and public health sector in the late 2000s, where we were trying to sell cybersecurity to healthcare. And everyone slammed their door in my face and said, "You're crazy. What are you talking about? We don't need to worry about this. Go away." And I'm glad to see that tide has now changed. So did that in the late 2000s. Went to the White House, National Security Council, EPA, private sector in here. So I've kind of watched the evolution of cybersecurity as it pertains to healthcare for quite some time now. And even as recently as like 3 years ago, I wrote an article about pandemics, or 4 years ago, cybersecurity during pandemics, which people said they're crazy to think about pandemics, and they're crazy to think about cybersecurity. And here we are today. So it's great to be here and looking forward to the discussion.
Well, fantastic. We're going to dive right into the questions. And I think this theme of this conference is, of course, lessons learned from the pandemic and how we can use that to craft better policy moving forward. So I think we would be mistaken not to acknowledge the last 2 years have been quite difficult. And so what we'd like to talk about is this unprecedented strain on healthcare and how we've grappled with all these types of different challenges, not just in the cybersecurity space, but at the same time witnessing an increase in cybersecurity attacks on the healthcare ecosystem. You guys have each individually worked incessantly to improve the security of the space and limit those types of attacks. But what lessons have you learned in the setting of COVID? And how can we take those lessons moving forward? Is there something in particular that really can draw a parallel to our cybersecurity preparedness?
So this is, I think, informed by my time prior to the Office of the National Cyber Director, but is very much integrated into my current work there. But I think the thing that we have become very focused on, and Director Inglis has talked about this a bit, is in some ways, and I would be fascinated to your thoughts on this, we sometimes still get into thinking of cybersecurity as an IT problem. The servers are down, we can't access our emails, whatever it is, and it is tossed off to the CISOs or the CIOs to sort of fix whatever fix means. But what we've seen, especially over the pandemic, is that when a hospital is hit by a ransomware incident, and it sounds like the simulation this morning covered this to a certain extent, that's a patient safety issue. That's a public health issue. That's not, at that point, that's not an IT issue anymore. And so looking at what we would tend to refer to, and Nitin's mentioned it, as sector risk management, is critical here. And I think what we have been focused on, and I have been focused on, is how do we bridge the IT and the what we tend to term the cyber physical, the OT side of things, so that when we have some kind of cybersecurity incident in healthcare, we are asking about the patient safety concerns. We are looking at how do you mitigate the patient impacts so that care quality is maintained as greatly as possible. That when hospitals are going on diversion, that we're not creating some kind of regional healthcare issue, which is what we saw in San Diego with the recent attack back in May. So bridging the IT, the OT, the cyber physical part of this, and recognizing cybersecurity as a patient safety issue that can lead to public health impacts, I think is where I've been focused, both in my previous role and in my current role.
Ditto. I think we need to look at this as a joint effort. And I think when I think back, I used to joke our hospital IT was literally in the basement. It was where their officers were located. And if it was an IT issue, we just let IT handle it. We need to look at what we're doing now really as a comprehensive response for an institution, and whether that's a public sector entity, a private sector entity, state, local, tribal, territorial government, or in the private sector. This is how are you as an entity going to respond? How are you as an entity going to protect your patients, protect your staff, protect your reputation? Because there is an aspect of this that deals with reputation as well. And how are you going to do that in an integrated manner? Because there is no longer that clear separation between IT and OT, or even between anything computer related and non-computer related, right? As we talk about things like how are we going to have effective communications internally to our staff? How are we going to have effective communications externally to our stakeholders and to the general public? We need to look at how we respond to cyber events as responding to an event, and not responding to a cyber event or a non-cyber event. And I think that has meshed and come closer over the last couple of years, because people realized we just couldn't do it alone. We couldn't do it in these isolated buckets. And people are also seeing the cascading impacts and consequence of what happens. And I think it's beyond even the hospital or the healthcare facility, to the community, to working with county emergency managers and others to understand what is the impact on the hospital, what cascading impact does that have on the community, and how best do you bring both county or state or larger resources to bear to help support that effort. And I think we have started to see that shift. The other thing I mentioned is that we need to start looking at risk as enterprise risk, and not enterprise risk from an IT term, but really enterprise risk for the entire organization. We spend a lot of time in our world talking about risk identification. We spend a lot of time talking about risk mitigation. What we don't spend time talking about is what I like to think of that third leg of the stool as risk acceptance. Because any risk we identify and we don't mitigate, we're accepting. Now, we always accept risk, right? I climbed some stairs earlier. I accepted the risk I may fall down. There's a certain amount of risk we accept in everything we do, but are we doing that eyes wide open? And as we look at how we address and mitigate risks, how do we look at that across the enterprise, and not in IT and non-IT, but across the enterprise? And to do that is to make sure that we're messaging effectively, not just to technical folks in the cyber arena, but to policymakers as well. How are we messaging to the CEOs? How are we messaging to the boards of directors so that they can truly understand the risks that they are accepting within their respective organizations, speaking both in a technical language and a non-technical language? So we get out of this fight, which I used to fight for, which is give me money for IT, give me money for physical security, for guns, gates, and guards, give me money for emergency management. And we all roll the dice. One year I win, one year our CIO used to win. That's not a way we should be doing business. We really need to look at this holistically from an enterprise perspective. And I think the pandemic has really helped raise that awareness at the institutional level. And I'm hoping that's something that's going to carry on as we go forward.
So we're going to move on to a particular piece of legislation that's recently passed, the Cyber Incident Reporting and Critical Infrastructure Act, now requiring hospitals to report when they've been attacked, and even sooner if they've paid a ransom. Now, how can we leverage that report to CISA to do more than just collect analytics? I mean, we all agree, we think the problem is much bigger than what we see in the news. And so reporting this is the first step, but how do we build upon that report to do something with that information? And to follow up on that, could we operationalize things like a cyber DMAT? Should we have a strategic technology stockpile to address some of these ransomware concerns? How can we build on that mandatory reporting to improve hospital resiliency in the face of an active cyber attack?
So I'll say, to us, the reporting isn't just about statistics and data. I said there is an element of it that's helpful to know, For example, in 2009, 2010, I went to California for a forum on healthcare cybersecurity, where a federal agency told me about all these cyber attacks against the healthcare sector. I said, hey, I work at HHS. Can I know what those are and what else you've seen? No, we can't share that with you. I was like, oh, cool. So I can't really advocate if I don't have the data to help drive that. So I think there is an element of it that does start talking about data, which is helpful. What we use incident reporting for, which is why we stress to people, especially today, to report early and to report often, is we're able to take that information, combine it with what we're seeing from our partners throughout the federal interagency, from the intelligence community, our law enforcement partners, working with our colleagues at NCD, to put that together to really understand what is that landscape and what are we seeing, what are the indicators of compromise, how do we help inform potential mitigation steps that we now share back out, not just with you, but with your colleagues as well. So how do we get this information back out, not to just your healthcare system or your hospital, but to every hospital in the country, or to other potential entities that might be impacted by a similar type of an attack. So it truly is giving that information back. And it's not just about, give it to the government, trust us, we'll file it away in the magic file cabinet, but to actually return something of greater value to all of you and to your colleagues across the nation. So I think there is value there. I think, I'm a huge fan of DMATs. I actually ran a DMAT out of New York, so I'm biased, but I think that, as we look at what role should the federal government play or can we play in some of this response, a lot of this, to us is, I don't see where CISA, even though we continue to grow, get to the point where we have somebody in every healthcare facility. That, we're responsible for 16 sectors, 16 critical infrastructure sectors. We can't get somebody in every single critical infrastructure facility. So for us, what we focus on, how do we go to one-to-many? So are we able to really help drive guidance, information that you can use to make your decisions? I have kind of a mantra on information sharing, and it's how do we get the right information to the right people in a timely manner that results in more informed decision-making? So if we can give you information to help guide your decision-making locally based on what we're seeing nationally and internationally, I think that's what can really help move that bar. How can we have a field force, which we do in communities around the country, of cyber advisors who can make sure we're linking in healthcare facilities, with the right cyber intelligence and getting that product information out there? How do we make sure we're getting that linkage with the HHS regional personnel and the HHS headquarters folks, and working together to do that? So we need to see, I think, over the next year or so, where a lot of this lands as far as how we get what those on the ground people look like, and are they hands on keyboards? Are they more strategy and guidance? Lots of states are doing work with the National Guard bureaus. Some states are creating their own cyber corps. I'm a firm believer, let's see where some of that lands first before kind of the federal government jumps in and offers a solution. Because I think we definitely have a role to play, but we need to figure out where we're most valuable on the ground.
Right. Well, and actually that leads me right into one of Director Inglis's favorite things, which is that for him, everything that the Office of the National Cyber Director needs to do is be value added. Because especially, and I'm sure he knows this very well, there's a lot of players in the cybersecurity space. There's a lot of federal agencies who are on the field, so to speak. And so, with the reporting legislation and every other policy development that it's occurring in federal cybersecurity right now, the way that Director Inglis explains this, and this may shock you, I'm not a big sports person, and so I'm possibly going to completely bungle this metaphor. But he talks about it like ONCD as the coach, and CISA and some of our partner agencies as CISA as the quarterback. And then we've got some of the other agencies like HHS who are, I suppose in this case, they would be the players. And the big thing for us, and especially for those of us who I think I can say suffered, I think suffered is the appropriate term, through some incident responses that we've had to cybersecurity incidents in the past. It's not always coherent. It's not always coordinated well. So we have people who know certain parts of information, but don't know other parts of information. And when you ask, sometimes somebody will tell you something and sometimes they won't. And at the speed that cybersecurity threats are able to manifest and start translating into patient safety harms or healthcare impacts, that's not good enough. And so figuring out how to coordinate, how to have a coherent federal response to all of these things, even broader than the incident reporting legislation, we're still working that out. And so ONCD, CISA, HHS, this is something that we work on every day. And I can promise you that because I am part of those conversations to try and do better. On the DMAC question, I am not a former paramedic, so I can't talk to that. But I know that we have seen, and Christian actually did a fantastic job testifying in front of Congress last year, explaining this about the regional impacts that we had seen off of ransomware incidents and what happens to healthcare systems when cybersecurity incidents occur. And I think there is a conversation that needs to be had, again, going back to this idea that cybersecurity incidents in healthcare systems are not IT problems. You wouldn't ask a doctor to fix an email server if something went down. You should not be asking an IT professional to diagnose and try to figure out how to treat a patient with insufficient, modern medical technology. But how do we do that to the points that Nitin was raising? Some states are calling on the National Guard, others are looking at standing up other versions of their teams. There's room to experiment, there's room to grow here and figure out what works for what places and what state, local, tribal, territorial organizations. I think our role, both from ONCD and from CISA, is going to be figuring out how to make that coherent. And so I think that's probably what we are going to be working on over the coming months.
Well, that's exciting to hear. And we're going to move on to another question, which is 10 years ago, when you asked healthcare delivery organizations, what's going on with cyber and what's the problem, they would all point to, well, we don't have the information. No one's sharing it with us. We're in the dark. And that has changed quite a bit through some of the amazing leaders in this room, leading organizations, the ISACs, the sector coordinating councils, CISA, of course, and others, have now turned what was initially complained about as a information poor environment to, hospitals are getting inundated with threat reports, to the point that many of them report being completely paralyzed to respond to all of these attacks, warnings that are getting sent to them. There's a new vulnerability with this. There's a new attack you should be concerned about in this regard. There's a new threat actor on the landscape. And so many of them reporting that they just don't have the resources to address all of that. So how would you recommend smaller, less resourced hospitals take advantage of all of this vast information and be able to triage through that to make sure that they can take advantage of the highest priority things, knowing that their hospitals, they don't have a lot of the expertise that many of the people in the room have?
So I'm actually happy to start us off, because I'm gonna take this in a slightly different direction, which is that with the sector in particular, I think we have to change the way that we're doing it. I don't think the expectation can be small hospital, figure out how to do this on your own. We as a sector, as a government, we need to figure out how to make that not the status quo and not leave smaller hospitals and other smaller organizations in healthcare or other sectors sort of out to dry like that. One of a very small use case of this is we talk about software bill of materials. There's a recognition that software bill of materials is going to mean just an inundation of additional information. And if you can't contextualize it, if you can't use it, if you can't pour through it and analyze it, what have you actually gained? And so there's a lot of discussion about tool development. There's a lot of discussion about how other organizations like ISACs, ISAOs, other things like that can play a role in helping comb through some of that information and make it meaningful, contextualize it for the various risk environments. And so I think that's more what we need to look into doing is, we have not been, and I hope I'm not going to get into trouble for saying this, I don't think so, or there would not be an Office of the National Cyber Director. We have not been particularly successful in managing cybersecurity threats over the past several years, decade, and so on. And so we can't keep doing the same things that we've been doing and expect that we're going to get somewhere different. So I think we have to change the way that we are approaching cyber threats. That's what we're trying to do with ONCD in partnership with CISA and other agencies, to the point that we change the burden that is on not just small organizations, but on all organizations of how cybersecurity is actually approached, managed, and responded to.
Yeah, I think we need to look at healthcare institutions, but really all critical infrastructure partners of all sizes. And I think in the past, whenever we faced a new threat or a new challenge, we've said we're going to tackle the large institutions first. Right. I mean, we saw this when grant funding came out in the early 2000s. We've seen this a lot of things that we'll get to that next. We'll get to that next. We can't do that with cybersecurity, right? Cyber actors, bad cyber actors are not only attacking large healthcare systems of 500 plus beds. right? I mean, if they were, that's easy, right? We can find our who we're going to work with and do that. They're attacking everyone. They're attacking urban, rural, they're large, small. So it's not about helping one subset of the sector. How do we help the sector at large? So I think as we look at this, we need to make sure we're doing a couple of things. One is communicating for all audiences. So making sure that what we're putting out isn't just only highly technical information that is not absorbable by anybody but the largest companies. So we've really tried to make sure that we're communicating in multiple levels, both technically and in that technical space, kind of across a vertical there, but then across a broader vertical of also being able to communicate effectively to policymakers, emergency managers, and boards, and elected officials, and those types of things. So I think there's one element there that we need to talk about is how do we change what we're communicating. We're also looking at CISA on our regional footprint. So we have hundreds of folks throughout the country in your communities and folks throughout there that can help translate some of that. So they're able to help kind of manage and differentiate when we don't have to focus on these hospitals for this because they have the infrastructure to handle it, to absorb it, to do something with it. We need to focus on these because they need that additional translation or support. So we're really emphasizing for our regional folks to look at where we can do that. We're trying to look nationally, and some of our colleagues are here that we're looking at how do we expand out nationally, working with associations, ISAC, CISAs, and others that use them as a force multiplier to help get some of that help and support out. And then we're also looking at how do we create tools and capabilities that are out there that folks can tap into. And whether this is through free services that we put up on our website and others that smaller institutions can take advantage of. I used to have a motto when I was in local government: if it's free, it's for me. And so there's opportunities out there that you can tap into resources that CISA has been able to develop, or that some of our partners have been able to develop, that can help raise that bar of resilience, just one step each time with those efforts. So we're really trying to cover down on multiple fronts. It's going to take time to get there, but we want to cover on multiple ways to get to that raising of that resilience bar, because not every solution is perfect, and ideal for every institution.
And I think that leads perfectly into the kind of a sub part of this question, which is not only if, let's assume these smaller organizations are able to triage through these alerts, identify the ones they need to act on, but yet still lack the financial resources to deploy some of even the most basic controls. For example, I'm always delighted to see in CISA's recommendations, turn on multi-factor authentication. There are a whole swath of hospitals in this country that can't afford to deploy that at an enterprise level. So you mentioned there are some potential free resources available for them, but for some of those more expensive enterprise security mitigation controls where they lack, and they simply will have to make the decision about, do I build a new clinic, or do I hire a new dialysis nurse to take care of or do I deploy the security control? For those that have to make that hard decision, do you think we need something more in the future? I'm thinking something like a larger federal bill to subsidize the cost of deploying some of these security mitigations for hospitals that can't afford it. Is that to truly move the needle and raise the sector-wide defenses? Are we talking about something like that?
So I think come up with a magic checkbook for NCD. No, I think that, before looking at, I want to look at how do we maximize what we have, right? So we have a lot of existing grant funding. We have through DHS, through HHS, through other sources. We have varying levels of investment. Do we even understand where we need to invest? So I think back to, again, my frame of reference when the grants came out in 2002, 2003, people just ran and bought stuff, right? And then 3 to 5 years later, we had all the stuff in our hospitals sitting in places we didn't know those rooms even existed, and we threw that stuff away, or we hoped it would work with something else, and we started at scratch. And by that point, we didn't have the money to rebuy everything, right? So we bought something that looked like it. Maybe it was as effective, maybe it wasn't. We didn't know what threats we were facing. So I really want to, as I look within CISA, I talk about us growing with intent. And as we start out and we go down to some of these paths, I want to avoid some of the challenges we encountered in the past. So as we look at funding and investment and sources and how we do that, I want to make sure we're just not lobbing a massive sum of money and saying we're going to go out and do, but how do we do this in a coordinated way that raises the bar? Part of it is how do we look at investing security first? Whether we're talking about physical security or cybersecurity, as we buy new technology, as we invest in new capabilities that you're already planning to do, how do you make sure you're going into that with a security lens? And how are we giving you the information to know the right questions to ask of those vendors and to to look into what you're purchasing. If you're already going to be upgrading, patient tracking system or medical record system, like you have that ability to do so with that kind of security first lens. How do we leverage those investments that are already being planned within various institutions, versus just kind of figuring out how do we fund a pot? I think we need to grow with intent. We need to look at those capabilities, what's out there, and then figure out how best do we resource this. I think when it comes to preparedness at large, and whether we're talking about cyber preparedness or preparedness against natural and man-made disasters, we're never going to have the money we need. We're never going to have a checkbook large enough. We're never going to have a bank account large enough in any federal department or agency, or even all of us combined, to fully eliminate and mitigate that risk. So how do we really bring this down to a local level? How do we understand where communities have already invested? How do we build upon those investments? And again, slowly raise that bar of resilience as we go forward.
Yeah, I think I would agree. I think that was a fantastic way of putting it. And the resilience question is one that is top of mind for Director Inglis. I should have mentioned this already. I'm failing at my ONCD duties here. The strategic intent document, which you can all, I'm sure, race to read, but it lists out, present and future resilience as a strategic pillar. But to what Nitin was saying, if we don't know what good resilience looks like, if we don't actually know what it means to be resilient, then throwing a bunch of money at the problem does not actually solve it. And so I think I do sympathize with CISA. My experience has primarily been in healthcare, but there are 16 different critical infrastructure sectors, and figuring out what resilience means in critical manufacturing versus healthcare versus energy, versus all of these different sectors with unique risks, with unique makeups is extremely complicated. And to put it primarily in healthcare, I think to what Nitin was saying, I think especially over the last several years, the healthcare sector has put in a lot of work through the Healthcare Sector Coordinating Council and through others in developing the policy that it needs to essentially do what was suggested of, we have to figure out what it means to be resilient. We have to figure out what we have versus what we need versus all of these things. And then we can figure out what the resource gap is, but we can't start with the resource gap and then go and somehow reverse engineer it. So I think the healthcare sector in particular has done a lot of work as opposed to maybe some other sectors in figuring out what that would look like. I don't know that we're there yet, but I think I would say from a resiliency perspective, and I would assume CISA would agree, but I think all options are on the table in terms of how do we get there? And if we can identify what the various options are, resourcing might not be the actual top thing that we all need. It might be that we need something else. And so I think as we continue to explore these different issues in partnership with HHS, with CISA, this is something that we're looking to really nail down.
And the one thing I'll add, I think, as we look at investment and we look at what organizations are doing, I don't know if we need to do better. I would say, I don't know if we've done, I think we need to do better at sharing information that helps build the arguments. When I look at my time in the private sector, my time in the public sector, whenever I had to go advocate for resources, it's one thing for me to go in and say, I need a bigger budget to invest in cybersecurity because CISA tells me people around the world don't like us and they're going to attack us. That has a 0% probability of success. Okay, probably negative probability. I'd probably be kicked out of the room. If we can go in and say, we need to invest more in my county, in my city, in my hospital, in my entity, because there's been X amount of attacks against similar sized institutions over the last 12 months that have resulted in these impacts, and these mitigation steps at this value can have an ROI that yields in this. And it's been tested and other institutions have done it, and this is where we're landing. That's a very different argument. At that point, I have a 2% chance of success, right? Which is way better than what I had before. But I don't know if we need to continue to do better at sharing the information that we have within the federal government on to help you build the business case. And again, whether you're public sector, private sector, what have you, so that again, you're understanding the risks that you're accepting. And I don't know if we've done that well enough. I'm not sure if we've shared some of those data and the impacts effectively enough to help build some of those arguments and cases. People invest because they want to, people are investing things they want to buy down risk, or they see their ROI. As you look at sectors and you look at investment in cybersecurity, people always talk about the financial sector. Well, the financial sector has a direct ROI, right, on this. Other sectors don't. As we've talked, I think healthcare's come a long way. It's been great to watch progress in the healthcare and public health sector, but we're having this ROI discussion with other sectors like food and ag and others where, it's a little bit of a bigger sell. And so how do we use information that we may have or that frankly we may take for granted that we have and share that in a way that allows others to make those arguments as well, and see what happens to resources from that perspective as well.
This morning, the attendees watched a simulated, high-fidelity clinical simulation where a ransomware event happened at a hospital, and a physician was trying to take care of two really sick patients, a stroke patient and a heart attack patient. They saw firsthand what the impacts could be on an individual patient. Recent ransomware attacks have really demonstrated more of not only impacts at particular hospitals that have been infected, but regional impacts. Some of them reported increased emergency department visits, ambulance volumes, diversion of ambulance traffic. And then, so how is kind of the thinking of not these cascading effects you mentioned earlier, ecosystems effects, influenced what you mentioned earlier, which is building more of a local focus, a regional focus? And have you seen success stories in a particular region be able to build a good cyber disaster resiliency plan on the healthcare side?
That's a good question. So I can't think of any specific region per se, but I do think there has been a lot more investment in collaboration with partners. So I think there has been much more the realization that any one institution cannot do it alone, and that it's not just about the other hospitals in the region, but all those other external stakeholders and partners that need to be present for that to execute. And so, partially I oversimplify it a little bit in the sense that, whether it's a cyber attack or a natural disaster or a power outage or whatever the cause is that is impacting the ability for an institution to care for patients or to bring in new patients, some of those response elements that are associated with that don't matter. It doesn't matter what caused it, whether, again, it was a cyber attack or a grid outage or what have you. So, one of the things that we have seen is a lot of great collaboration where healthcare is at the table more than they were in the past. We're often, I think healthcare used to knock on the door, they try to jam their foot in. If somebody said hello, they'd be pushed away. Or really being, and I think the pandemic really, and it's sad, it took a pandemic to do this, but really people started to see healthcare as a true partner and necessary collaborator in a lot of these efforts. So I think that those discussions are happening. They've been happening for a while in pockets, but I think they're happening more globally now than they have in the past. Because in the pockets I feel that they were happening in the past, or pockets that had incidents that have led to that, right? So whether you're talking about wildfires or tornadoes or terrorist attacks, these were communities that because something happened, they felt the need to come together and to look at this. I think what the pandemic showed us is that there was no, everyone, right? There was no areas that were exempt from it. So I think it's really brought healthcare into that fold. And I think we're going to see a lot more of that collaboration transitioning from a public health emergency to cyber and other incidents. And really, once those relationships are built, it doesn't matter what the threat actor is at that point, right? Or what the cause is, because that ability to look at, patient decompression, patient interfacility transfer capabilities, those types of things are going to be there regardless. We just need to bring cyber into that fold.
Mm-hmm. No, I'd agree. I mean, I don't want to throw a bunch of acronyms and a bunch of bureaucratic nonsense at everyone, but the concept that we've had and the model for risk management at the national level for a very long time is the Sector Risk Management Agency model. Previously known as a sector-specific agency. If you hear somebody say SSA, you know that they've been involved in this for a while. But the whole idea was that there are agencies who are designated as the ones who, for their sector, they are supposed to be managing the risk. And it's not, oh, this agency is the SRMA for cybersecurity risks, or this agency is the SRMA for physical risks. You're just the SRMA. So HHS is the SRMA for healthcare, and that means that managing cybersecurity risks, managing all hazards risks, it's all part of the function. And to some of the points that have been made, Nitin's just now and previously in the discussion, I don't think a doctor or a patient necessarily cares why they can't go to the emergency room closest to their house. If there was a power outage, if there was a cyber attack, what have you. And certainly my experience has been, we have, because of this history of responding to hurricanes, responding to wildfires, responding to these other incidents, at the state and local level, you have those mechanisms for how those things get escalated, how they get handled, how they get translated up to FEMA, to HHS, and how those kinds of things get translated back down. We are still, I think, in the process of identifying the connective tissue for how to do that in a cybersecurity incident. And part of it is just reframing, right? Part of it is breaking that, the wall that seems to have gone up between this is a cybersecurity incident and this is something else. And so I think that that's going to continue to happen. And as that does, I think that is where we're going to start seeing some of the success stories of state and local regions and others who are able to comprehend that, to build that into their processes. And my hope, of course, is that then those best practices start to spread, assisted, of course, by organizations like CISA and ONCD, who will be very grateful to help do so.
I just want to take a quick poll in the audience. Who here identifies as a hacker? No, yeah, they are among you. Look, see. One of the greatest success stories over the past decade has been the strengthening of stakeholder partnerships. Perhaps none more so than the contributions to security researchers and ethical hackers, the number of important medical devices and infrastructure initiatives. The CARES Act offered an opportunity to rapidly formalize some of these partnerships and bring in outside cybersecurity expertise, hackers, in a way that seemed to be very beneficial to CISA and ONCD's mission. Can you speak a little bit to the success of those initiatives and the thought of how in the future engaging with the hacker community and security research community could continue in that positive way?
It has to, right? I mean, it's not a question of does it or should it, or it has to, and it has to continue to expand. I think things like CARES Act has been instrumental for us to bring on expertise, right, into the organization. And so it's been extremely helpful from that perspective. But I think it's really allowed us to tap into, to bring in-house expertise we traditionally collaborated with. I think that there's immense value in collaboration. I'm not anti-collaboration by any means, but it's one thing to collaborate. It's one thing to have somebody in-house, 60 hours, 70 hours a week. Is I think what we make people work, to help us. We're looking at how do we continue that as we go forward, right? So the CARES Act has a finite window of time, but it's not the end, right? That was, I think, kind of the beginning to help us go forward. We have new authorities now. We've been entrusted with Congress for the cyber talent management system. So we have new ways of hiring people into cybersecurity fields here at CISA that we've not had in the past. We don't need folks to navigate, what can be a challenging way to come into federal service, to recruit folks with expertise, and to assess expertise as they come into the organization. So I think, CARES Act was a great kind of launch pad to where we need to go, but it's not the end. It's really going to help us, come forward. We've been able to bring in healthcare expertise, been able to bring in, obviously cyber expertise, ethical hackers, kind of across the spectrum, and really help us, learn from them, jumpstart that, and really help us understand what is it we need to focus on as we go forward. So.
ONCD, the CARES Act was specific, I think, to CISA, if not other federal agencies. So that was not something that ONCD necessarily got access to. But I think the point I would make here is if it was a model that worked, then ONCD does have a workforce development directorate. This is something that we acknowledge, as I think everyone acknowledges in the cybersecurity workforce shortage. But this is something that we need to address. And then, like Nitin said, the ability to bring people in-house is really unmatched in its ability to influence an agency's thinking in the way that we want to see it go. So to the extent that that is a model worth replicating, I think that's certainly something that should be explored in terms of making sure that the agencies have access to the expertise that they need when they need it. And can leverage it in the ways that they need to.
I will say, CISA's goal is not to become the expert in all 16 critical infrastructure sectors. We will never get there. We should never get there. We have expertise in the sector risk management agencies. We have colleagues at FDA and others that bring an immense amount of value. So we could hire the most amazing expert on X. That's one person, right? And HHS may have an entire division department focused on that effort. So to us, it's how do we bring in, to some extent, translators, right? People who understand, who can make that connection back to that community and bring a lot of that forward, and make sure that we can build that relationship and continue to thrive in that area. But we have people all say, like, CISA, where's your experts? Like, the experts are not all in CISA. The experts are throughout the federal interagency, and our ability to tap into those sector risk management agencies is what's important. There's a reason we designated sector risk management agencies that are outside of CISA and outside of DHS. So we want to make sure we continue to foster those relationships as well.
Well, this has been fantastic. And with the last about 6 or 7 minutes, we'd like to open it up for audience Q&A. So we're going to go ahead in the back first. And if you could please keep your comments brief, your questions brief, as we try to get as many questions as possible.
Hi, my name is Max Justice. I work at HHS. I'm the cybersecurity program manager with 142 souls protecting the healthcare data of 1 in 5 Americans. We have the zero trust model. I don't think it works. In fact, I'm putting together a dissertation, my PhD dissertation on a trust model. You talked earlier about trust. We don't trust our government. We don't trust each other. We don't trust our politicians. We don't trust our neighbors. We have to start trusting if security is going to work. I've been a Marine. I've been protecting this country for years. The only way that we survive is we do it together. And if we have a zero trust model, it means that we go at it alone. We have to do it together. I'd love to work with you and others on developing a trust model. Thank you.
Is it my turn? Hey guys, you talked rightly about cybersecurity incidents within hospitals as a shared enterprise risk. And we talked about the challenges of budgeting and funding cybersecurity resources in hospitals. But just sort of cutting to the chase, inside of a hospital, given this right approach to shared risk, whose budget should cybersecurity investment come out of?
So I will give the most bureaucratic answer possible, and I realize that this is going to be minimally satisfying. I think it's going to depend on the organization.
Yeah.
I think the organization needs to sit down. They need to look at how they've set up their critical engineering, their cybersecurity teams, the entire organization, and figure out where it fits. I have been working with a lot of medical device manufacturers and healthcare delivery organizations over the years. And every time we think we've got a recommendation that can fit across the board, we've got that one person who's like, nah, that's not going to work for us. So again, I'm sorry that I cannot give you a more satisfying answer, but I really think it depends.
My answer might be less satisfying because I think it also depends. I think, as we've talked to healthcare, large healthcare systems, right? The way that they set up their investments vary, right? So some are tackling IT and cybersecurity on a system-wide perspective where they have centralized IT and those capabilities. Others, even in healthcare systems, are doing it on a facility by facility basis. So I think there's that element there. I can say my hospital is a public benefit corporation, so we actually had direct grant funding as well. So we could, if we were in that same situation now tackling cyber, we could do it that way, which is something different than a fully private hospital might have access to. So I really think it's going to vary on the institution and their setup. But I think this is why we're really trying to focus on escalating the understanding of the risk acceptance to the CEOs and to the boards. Because if we can get the right people asking the right questions, and frankly, not just taking, yeah, we got this as the appropriate answer, but really diving in a little bit deeper, it allows them to figure out, which pot do we take it from. But if they don't fundamentally understand the risks that they're facing, they're never going to invest in it, no matter what pot may have the money to come from.
Well, first of all, on behalf of a grateful digital universe, thanks for who you are and what you do and why you do it, because the only time you hear about hacking or cybercrime is when the criminals win. So, just thank you. So when it comes to cooperating with the ISACs, I had dinner with the director of one last night, and maybe offline, I'd like to just give you some feedback because they're very eager to help in this mission and would like to do that, because it'll be helpful to you. So my question is, in a general sense, the distillation of the complexity of cybersecurity. This stuff is too hard for most people to get their heads around. What thoughts do you have about messaging effectively?
So I use me as an example, right? If I can understand it, we can get a broader community to understand it. I'll pick up my colleague Bo, right? Like, we have very different levels of technical acumen, extremely different levels of technical acumen. So how do we get our products out there in a way that I understand and that he understands it, right? So making sure that we're able to do that in the right way. So that's what CISA's really been focusing a lot on, is as we get information out there, making sure it speaks multiple languages, because there are times where we're not going to distill to a single message to cover the entire spectrum of community, right? We need to take that message and actually share it differently for different communities. So we're looking at that. And we need to do more of that. A lot of the other thing we're really focusing on is we call, in the bureaucracy, multi-seal, multi-branding of products. I think as we talk about the healthcare sector, CISA publishing something, under a DHS logo for the healthcare sector is not as valuable as something that HHS has collaborated with us on, and is both an HHS and a DHS product, or the FBI HHS DHS product, or an NSA HHS FBI CISA product, and really getting that out there, and then making sure that as we all look at it from our respective lenses, that we're speaking to the right audience. So if we have something that's going out to medical device manufacturers, having the FDA intimately involved in that process, making sure you're speaking the medical manufacturer's language, that we're using the terms and we're using, the right, examples and those types of things, is what's going to make that product more valuable and ensure that it speaks to that audience. So within CISA, we've kind of committed that we want to multi-seal every single product as widely as we can, with our partners, not just to give it credibility and validity, but also to make sure it speaks to the audience effectively, because it needs to. And we are not the expert in every sector. We cannot ensure that what we're saying is doing that. So working with those partners is what's going to allow us to make sure that message is heard.
Yeah, all of that, and I don't want to belabor the point. The only thing that I think I'd add is, one of the things that I've seen make cybersecurity communications effective is why. Don't tell me to patch something because it needs to be patched. Tell me I need to patch something because if I don't patch it, a medical device patient could be put at risk and what the risks are to their health. And then you get a different response. So in addition to everything that was said, I think it's really focusing in on the why, especially on the audience basis.
Next question.
I was curious if CMS is in the conversation. In June last year, OIG published an audit saying that CMS doesn't systematically assess medical device cybersecurity from hospitals, and that they recommended CMS start to do that. Just notable absence in the room. Curious if that's starting.
So I can't speak to that specific report, but I will say that CMS has been an active participant. So we talked about the sector coordinating council. There's a government coordinating council side, right? So within the healthcare and public health sector, CMS has been an active participant for many years. I mean, even back when I was there in 2008, they were an active participant. I'm assuming they're continuing to be an active participant. So HHS ASPR is able to bring together FDA, CDC, NIH, CMS, and others to have those conversations on how they want to look at tackling these challenges within the sector. So I'd say, CMS is definitely at that table for that discussion. So as we tap into a lot of the cross-sector efforts, obviously the SRMA will speak kind of for the sector at times, but it's usually informed by that broader audience.
What he said.
We want to respect our panelists' time. And of course, I know we have many more questions. It just means you have to come to the next CyberMed in San Diego in October-ish. So please set your calendar now. Please give a round of applause to our panelists. A true honor. We thank you for your time.